Good afternoon, everyone. And we're at the end of the day, and it's an hour later, technically, or an hour, whatever we did. We fall back, went forward, whatever we did. So I think we're all trying to get used to that. But many people ask me, why do you have Peter Lillian as your name? Well, I figure I get that out right now. Peter is my father's name. Lillian was my mom's name. So I took my father and my mother's name, and my name is Lillian as well. But I'm very happy to be here, and today has just been so wonderful. All the things that you've talked about over the last few hours have really come home to me and affirmed what we are trying to do in long-term care. As you know, long-term care is the orphan of healthcare. We don't get a strong voice lots of times, and our reimbursement is always, we're fighting always, every tooth and nail to be able to get what we need for our residents and the people that we care for. So what we decided to do in long-term care, since we were not going to, well, we the Carmelite sisters anyway, we knew we weren't going to get reimbursement for the palliative care that we did every day. So we had to stop complaining about it and try to figure out how are we going to be able to do this and have everyone feel like that they are doing what they should be doing each day. When we looked at it in 1929, when our founder started, that's what she talked about. Each person is unique as an individual. And we have to look at it, the whole person, not just the physical care of that person. And a good friend of mine, Dr. Michael Brezier, maybe some of you know him from Calvary Hospital in the Bronx, he had talked about the 5 domains of pain over and over again. And I thought, well, if we can do the 5 domains of pain well for people who have terrible cancers, we need to look at the 5 domains of pain of all people, because we're all experiencing that. And I'm sure every single one of you in this room has experienced suffering in some way. Certainly physical, emotional, spiritual, mental, and our familial pain, that family pain, especially what we see when we have residents come to our facilities. So part of what we did, which was no different than what we had been doing since 1929, is we organized it and we formalized it in a way that would allow us to keep maybe more tabs on it. So the first thing we did was start a steering committee, and that steering committee was made up of the nursing staff, medical director, administration, social service, and pastoral care. And they sat down and said, what do we need? What are the things that we have to do to support our staff throughout the facility? Because we can't call in a palliative care team. We don't have one to call in. We are it. We are the palliative care team. So first of all, one of the things that we said was we needed education, and I'm grateful to LNAC and for all that they do, because it was LNAC that we attended, myself and another sister said, you know, we can take this curriculum and we can modify it somewhat for our long-term care. And a lot of it we can still use. And then we also have other resources. We have CAPC. We have all these other resources out there that can help affirm what we do in long-term care. Part of what you probably already well know is in long-term care, most of the people we care for have some form of dementia. Anywhere between 70 to 75% of the people that we care for have dementia. That adds a whole new level to what you do with palliative care. It's nice to have all the tools and the assessments and such, but how do you ask somebody, is your pain excruciating? What am I going to do with that if I have Alzheimer's? Does your head hurt? I can answer yes or no to that. So we had to modify some things to be able to help us be able to get the full assessment for the people that we were caring for. We also had all the very alert people, the congestive heart failures. We have the restorative nursing people who come in. So what we did was the Palliative Care Steering Committee comes together in every home, talks about what are the trends, what are the things, what are the illnesses that we are dealing with, and what do we need to do as far as developing our education. So they oversee the evaluations, they create an environment of compassionate care, and the steering committee then facilitates monthly meetings with each unit. So each unit, each floor, however you call it in long-term care, is the palliative care team. So that's made up of your nurse manager, of the social worker that's assigned to that unit, the pastoral care person, the CNAs, the housekeepers, the dietary, everyone is a part of palliative care. And they encourage this discussion every day to take place so that on the 24-hour report, if there's somebody having difficulties with some kind of pain, then that is reflected on a 24-hour report so that everyone is aware that this unit, this person, is having difficulties with family pain, and we have to address it. Each floor, as I said, is we look at these different interdisciplinary approach. You know, when you think about it, If we don't instill in our entire staff what palliative care is, then the housekeeper is going to miss a palliative care moment. They can very well go in and be cleaning a room and say, this resident, after they got off the phone, seemed very upset about something. And the nurse goes in and doesn't even see it, only because the resident has gone over it. It's that person, that housekeeper, that has to alert nursing, alert pastoral care, that there's something else going on with this resident that we have to look at. So the unit teams are chosen by the Palliative Care Committee to make sure that those teams are intact and that they are passing all this education on to the rest of the team. And each unit team meets. They talk about what the different pain things that are happening on each of the units. And they might educate the families, the residents. Educating the families, we found, was key. Because we can talk dementia all we want, but if you don't understand, what dementia means, that it's not dementia's the umbrella, there's different things causing the dementia. There are different expectations the families may have and that we have when we're trying to care for that person. So the palliative care unit team has a coordinator, and they meet weekly. And it's not like we added on time. They're already doing this. But what we're asking them to do is, remember, talk about palliative care when you were talking about anything that may be going on with your residents during that week. And then they report back to the steering committee if there's something that they can't address. We want them to be self-sufficient and be able to, each unit, if there's something, not wait for a team meeting, but to take care of it immediately if we give them the proper tools. And in what we thought and we felt to create that culture were 4 very important things. Have education, which was comprehensive, and again, I'm grateful for LNAC for allowing us to use a lot of their material. Using an assessment, and we took time. We did a pilot program for six of our homes, and we did assessment after assessment. We had too many questions on some of those assessments. And then we learned 3 or 4 questions were sufficient to find out about where this person was in their need. We were really good clinically. We had that down pat. We knew what to do with our residents when it came to their clinical needs. But boy, when that person came in with that broken hip, there was a lot more that took place. It wasn't a hip in room 345 broken. It was a person who just went outside to get the mail and broke their hip, and their entire life has changed. Talk about emotional change. Talk about emotional pain. Talk about spiritual pain. That's what we need to concentrate on, because the physical we were really good at. So we decided that our assessments really needed to ask just 2 or 3 more questions that allowed us to get to the heart of what that person was experiencing. And then we felt that each level of care, each resident, each sister, each staff member, each family member needed education. So we provided that education and to come together to find the best possible solutions for each of the residents. And obviously reevaluate, and we keep reevaluating. We reevaluate all the time our palliative care and trying to figure out what is the best way that we can do that. When we did the education, we decided that it had to be all staff had to understand the difference between palliative care and hospice care. And then we came to the conclusion that every person coming into our facility was being put on palliative care. Why were they coming to us? They were coming for a reason. Otherwise, they'd be staying at home. So they had to be assessed in all 5 pains, every single person coming in. As we did that, the education included what is palliative care, identifying and managing different types of pain, understanding the mission, the culture, be an advocate for the residents. We have residents too, that reminds me of that story of a man who had a really painful knee. He went to the doctor and he said, "What do you expect? It's 85 years old, your knee." He says, "My other knee is 85 and it's not bothering me." So taking a look at that and saying, just because I'm old doesn't mean I have to have pain, physical pain. So we wanted to make sure that they were understanding this is a person. I don't care if they're 102 or 22. They were all expecting and needing the same things. And understanding what it meant to be a disciplinary approach and having that ongoing education and respecting each resident's culture was so important to us. To understand that we didn't just care for, the same person coming through, that they each have their own culture, their own faith traditions, and what was it that might be missing that created maybe some concerns for them. As we looked at our education, we began to see that we needed to refine it, and this is what we're implementing going forward. That we decided that a lot of things are already out there, thanks to LNAC, thanks to CAPSI, thanks to many of you out there because you have so many wonderful programs. What we really needed to do is concentrate on the culture. And how we were going to do that was to look at different ways of doing the education. And basically now we're at understanding communication techniques, understanding how you can put the palliative care, when you came up with your reasons why you need to help someone or to make some interventions, it should become a part of a palliative care plan. So once you evaluate it and it was working, then it should become a part of that plan. And then our palliative care culture, what we've changed that to, is to help people to understand that, sometimes it's not the physical healing that tells you that you have allowed someone to heal. It's, did we bring peace? Are they peaceful of what's going on with them? And what does that mean? And how do we express that? So we're concentrating now on helping people to use palliative care language always. What are your palliative care moments every day? It's that maintenance man who realizes this person who has congestive heart failure and is hungering for that breath or has COPD, that air conditioner needs to work well. And it doesn't mean it's last on the list because you've got 15 other. That's the palliative care moment when you say, I know I still have to finish painting that room, but wait, I'm here for palliative care. I need to go in and help that resident and fix that air conditioning. It's having the dietary person to know that this person's favorite food is to have that cranberry juice every single morning at 9 o'clock. That's a palliative care moment. So we want to instill in our staff that everything you do should be about the whole person, not just about one part of the person, because we're not all one parts. We are all whole people. And make it a mission to discover what the individual resident cares about. So in our palliative care meetings, we begin with a prayer. We discuss the reason the person has come in. We may rotate leaders between social services, maybe pastoral care, maybe nursing. And there's a worksheet, so when you come, you're prepared. You have your worksheet and you say, these are the things that I know about this resident. We already know about their diagnosis and their prognosis and all of that, but they're really having a hard time with their granddaughter that just moved away. Now everything else is wrong. So who's going to concentrate and help with that person? So those palliative care moments that we find are identifying the types of pain that each resident is talking about and what their conversations and those difficult conversations that people just have a very hard time doing and saying and being a part of, and using that person-centered messaging to really know that you really listen to me. How are you, Mrs. So-and-so? Oh, I'm fine. I wish my daughter were here. Oh, do you want me to open the window so you can get some air? Wait a minute. You've missed what they just said. If you're in there, be attentive to those palliative care moments. So what we wanted to do is to make sure that it is unit focused, that they establish a comforting and healing environment, educate and have mentors who, when on the unit, when people come onto the floor, that they too are available to be able to say, especially the new staff, to help them to understand what it means to be truly palliative care. The evaluation time that we took place is we looked at doing some focus groups when we did our pilot program, and we learned from that. It's funny that how sometimes people will say, the more you ask the questions, now what do? We got the answers. Well, use your skills. That's what it's for. We can get people so involved in check-off boxes and marks and here and there and everything else that before you know it, they forget why they're there. So we can't make it that it's just about, the reimbursement. It's just about the MDSs and such. So the palliative care, what we see is that we have to continue to improve it, provide compassion always, and maintain a constant cycle evaluation to make sure we're doing what we need to do. How do I see that we can be able to support long-term care? Well, there's lots of things. It would take me forever, and I know I only have a minute left, so I can't tell you all of it. But what I do want to say, I know we've been talking about reimbursement. Yes, wouldn't it be wonderful to be reimbursed for a palliative care nurse and long-term care who would be responsible for all the education that we need in palliative care, and everything else will stem from that. So when everybody comes into that facility, they are being educated in all those areas. We wouldn't need to worry about all those mandatories that we have to do because it'll all stem from palliative care. The other thing that I think that's really important is that we need to start looking at more and more specialization in geriatric care. What I heard today, I'm so grateful that that's already happening, and that's wonderful. But we need to look at that even more deeply and to see what does that mean. And in our case, and certainly long-term care, it's really looking at the dementia palliative care because there are so many issues that we have to deal with over and over again. So that's my scoop for the day. And I want to thank you for being here and being part of. We do have our implementation manual and guidebook that you can download from our website, which says a lot about what I've said today. So thank you very much.